So good evening, colleagues. Welcome to this weekend tutorial. And we're going to be looking at something very crucial in the anesthesia and critical care. That is brain CT scan, basics and interpretation. So like usual, I have some case-based MCQs for us to quickly tackle. All right, the earlier we answer them, the better, so that we can proceed to what we have for today. So the first one, I hope this, okay, the first case is a 45-year-old male patient who is brought to the ICU after a high-speed motor vehicle accident. His glucose coma scale is 7/15, and a no-contrast brain CT has been performed. The scan shows a biconvex hyperdense collection in the temporoparietal region, not crossing suture lines. So what is the most likely diagnosis? Anyone? A, subdural hematoma, B, epidural hematoma, C, subarachnoid hemorrhage, D, cerebral contusion. Anybody?
Epidural hematoma, sir. B, epidural hematoma, sir.
Okay, correct. Why? Any reason why you're choosing epidural hematoma? What in the
Yes, sir, because of the nature of the presentation of the biconcave hyperdense.
Okay, correct. Epidural
Okay,
hematoma.
there's a high speed.
Epidural hematoma is correct. Let's go to number 2. A 72-year-old hypertensive patient presents with sudden onset or left-sided weakness. A non-contrast brain CT performed within 2 hours of symptom onset shows loss of gray-white differentiation and sulcal effacement in the right middle cerebral artery territory. What is the most likely diagnosis? No chorus answer. I want to see who is answering. Anybody? Dr. Friday Chisoga, are you answering that question? Okay. Bless, who is answering?
I'm not sure about the answer.
Okay.
Yes,
anybody that is sure should answer for me, please.
it's hemorrhagic stroke, sir.
I don't agree with you. Anybody else?
Acute ischemic stroke, sir.
Acute ischemic stroke. What's in this presentation in the brain CT that tells you is acute hemorrhagic stroke? I mean, acute ischemic stroke and not hemorrhagic stroke.
The gray-white differentiation, and so those are like the early symptoms of stroke on CT scan.
Okay.
I think of ischemic stroke.
Okay, what again?
And the sulcal effacement, the two, this thing that was shown.
Beautiful. All right. So it's acute ischemic stroke. You're correct. Where are you from? Which center are you from?
Sir?
Which center are you from?
Federal Medical Center, Abuja.
Okay. All right.
Yes.
You have CT scan in your hospital?
Yes, sir, we do.
Beautiful. Okay, let's do the third one. Okay, a 60-year-old ICU patient with a history of subarachnoid hemorrhage develops progressive drowsiness and confusion. A brain CT ordered shows dilated lateral and third ventricles with a normal-sized fourth ventricle. What is the most likely diagnosis? Anyone?
Obstructive hydrocephalus.
Obstructive hydrocephalus. What in this presentation shows obstructive hydrocephalus?
The dilatation in the lateral and third ventricles.
Yeah, that shows hydrocephalus, but what makes it obstructive and not normal pressure and not communicating hydrocephalus?
Because the size of the fourth ventricle is normal.
Beautiful. Well, beautiful. So what do you think is causing this? Most likely a mass effect, isn't it?
Yeah.
All right. What is the other name for obstructive hydrocephalus?
Non-communicating.
Non-communicating, correct. Which state are you from?
From Malawi.
Okay, correct.
Yeah.
So you do regular brain CT in your center?
Not actually. We don't usually do CT scans.
Okay.
Like the scans are usually reviewed by the neurosurgeons.
That is what I want us to change here. That's why I'm bringing this here. If you're
All
working
right.
in ICU, you should
All right.
have the basis of brain CT interpretation. All right, you are the first person that they will send the scan to before even the neurosurgeon comes, especially in ICU. If you have an open clinic, they will send it to you. So, but good answer, correct answer. Let's look at the fourth one. All right, so a 55-year-old patient with a severe traumatic brain injury is intubated in the ICU. A brain CT shows effacement of the basal systems. There's a midline shift and compression of the lateral ventricle. What is the most likely diagnosis here? Anyone? We're quiet, people. Are we thinking? If it's a steeplechase, your time would have rang the bell. Are you going to let this pass?
It's ankle herniation.
Sorry?
Ankle herniation.
What in the history? Correct answer I will give you. But what in the history? I want to be sure you didn't answer the guess.
No, because of the close proximity to the basal system. So because there's effacement of the basal system, and the fact that the ipsilateral lateral ventricle is also obstructed. So that's because of the ankle herniation.
Beautiful, correct answer, correct answer. All right, and there's a midline shift. All right, so correct answer. Which center are you from?
I'm from Nelson Mandela in Mthatha, South
Where?
Africa. South Africa.
South Africa.
Nelson Mandela.
All right, my South Africa people, correct. So you do brain CT regularly? You review brain CT regularly?
Yes, we do.
Beautiful. You work in the ICU?
Yes.
Beautiful, beautiful. Professor Dylan is a friend, so I know him very well. Okay. So let's see the last one. So a 38-year-old immunocompromised patient presents with fever, headache, and utter sensorium. A brain CT shows a ring-enhanced lesion with surrounding edema in the right frontal lobe. What is the most likely diagnosis here? Anyone? Oh, don't go to the answer. Anyone?
Brain abscess.
Okay, who answers? Sarah or Charlie? Who is going to get? Why is it brain abscess?
Because of the presence of the ring enhancing lesion surrounding edema.
Beautiful, you're correct. Which center are you from?
Lutz.
Lutz. All right, Lutz is Lagos University Teaching Hospital. There are a lot of people that don't know abbreviation. Please say your center very well so that we can know. So you do brain CT regularly in Lutz?
Yes, sir.
Okay, and you have a chance to review the CT?
Yeah, most times the neurosurgeons do the review, or the neurologists do the review.
That's what I want to change, okay? Neurosurgeon shouldn't be the only one, all right? As a resident working in ICU, once you order for a brain CT and it comes, you should review. In fact, you should bring the neurosurgeon, hey guys, I think there's something here, all right? And I think we need to do something, even as an anesthetist, all right? So that is the idea of this. Well done, everyone, okay. So we go on for today. Okay, my slide is not moving. Okay, so these are the answers, okay? We'll look at them as we continue. All right, if I'm going to ask you questions in your exams, whether national, West Africa, or Canexa, you can be sure I'll bring some of these questions there. So just relate with it. So the learning outcomes for today, at the end of this lecture, I expect you should be able to understand the basic principles and technology behind CT imaging. You should be able to recognize when to use a brain CT scan and its indication. And you should be able to systematically interpret a brain CT scan and identify normal pathological findings. And I expect that at the end, you should be able to apply your knowledge of brain CT scans to real-life clinical scenarios. Okay, so we'll follow this outline. All right, so let's start. Brain CT scan is one of the most commonly used imaging modalities in clinical practice, including anesthesia and ICU. It provides a quick and critical information that guides diagnosis and management of emergencies. And it has several advantages over your MRI, especially in the acute setting, by offering rapid information regarding surgically treatable lesions. All right, this is very critical. And as such, is especially important in the hemodynamically unstable or neurologically obtunded patient. All right, in as much as MRI has advantages because it gives you more detailed information, vascular tumor regions, CT has this advantage because it gives you a very rapid information as regards to treatable lesions, all right? So by way of history, CT scan was developed in the early 70s, 1970s, and the first clinical CT scan was done around 1971, 72 on a patient with a suspected brain tumor, all right? Sir Godfrey Hounsfield and Alan Cormack. Sir Godfrey Hounsfield was actually an electrical engineer, while Alan was a physicist. All right, they are credited with inventing the CT scan, and they won the Nobel Prize in Physiology of Medicine in 1979. Now, we've moved a long way, all right, due to technological advancement, because the early CT scanners usually took several minutes to obtain a single slide. But the modern multi-detector CT scanners can generate high-quality images within seconds. Okay, so the principle, it lies in the fact that CT scans use X-rays that create detailed images of structures of interest, all right? And this is done by passing a narrow beam of X-rays through the body at various angles. All right, detectors on the opposite side will measure the amount of X-ray that is absorbed by the different tissues and their content. The data that are collected, they are therefore processed by a computer to construct the cross-sectional images. And this is what you see, giving a detailed view than plain X-ray. All right, so I'm sure many of us have seen a modern CT scanner before. All right, this is just to remind you what it is. So the scanner is here, all right, where narrow beam of X-rays are projected to the body of interest, area of interest, and the detectors are behind, which detects the X-ray absorption by the different tissues, all right, or tissue content. Okay, and this is what you see in modern CT scanners. Okay, so Godfrey Hounsfield was credited with the units, okay? And they call it CT units or Hounsfield units. And it measures the different tissue densities, and they are used to identify different abnormalities. So water has 0 HU, well, that is Hounsfield units, while air is minus 1,000. Bone, which is the most dense most of the time, is plus 1,000 Hounsfield unit. In the brain tissue, the gray matter is denser than the white matter, and it has 30 to 40 Hounsfield units, and the white matter 20 to 30. Okay, so it's this Hounsfield unit that helps us to differentiate between hyperdense lesions or isodense or hypodense lesions. Okay, so this is just a diagram to show you how it varies. All right, so tissues with minus 1,000 units will apply black or hypodense, while tissues with higher Hounsfield unit, like blood and bone, will appear white, hyperdense. All right, like I told you, water is 0 Hounsfield unit. Okay, so there are two types of brain CT that are commonly used in clinical settings. We have the non-contrast and the contrast enhanced CT. All right, it's important for you to know which to order for your patient. So the non-contrast CT is the commonly used one, especially in detecting hemorrhages, calcifications, and all that. While the contrast enhanced CT highlights blood tissues, vessels, tumors, and they are usually useful, all right, to highlight these blood vessels. Please, people, can you mute your mic? We keep saying this every time. These sessions have been recorded. Okay. All right, sorry for that. Trying to mute the person that just came in and forgot to mute his mic. Okay, so there are different CT planes that we use. The common one, the axial plane, all right, divides the body into superior and inferior sections and useful for evaluation of trauma, stroke, and hemorrhage. We have the coronal plane. Okay, oh my God. Okay, the coronal plane divides the body into anterior and posterior section, okay? And is ideal for examining anterior brain structures, mass lesions, hydrocephalus. And the sagittal plane divides the brain into right and left sections, all right? And this is usually used for viewing midline structures like your vas cerebral or your corpus callosum. Is also useful in detecting herniation like the uncal herniation we talked about, and also useful for brain stem pathologies. Okay, so you need to know the CT plane that you are viewing in your CT images. Okay, so these are the key terms. I want you to look at the image on the right. The first arrow, the upper arrow, is showing a hypodense lesion, okay? Hypodense because it appears dark, all right, in relation to the brain itself. The brain is isodense. So compared to this, you see that this is an hypodense lesion. Why the one inferior to it is hypodense. It appears white, whiter than the surrounding brain tissue, okay? So these are the key terms that helps us to differentiate between different lesions and pathologies in the brain. So indications for brain CT 7S, all right, in case of stroke, whether ischemic or hemorrhage, ischemic stroke is very important because it is important for you to rule out hemorrhagic stroke if you are going to thrombolize your patient. So it's important. Seizure disorders, patient with severe TBI, patient with space-occupying lesions, patient with signs of intracranial hypertension, patient with suspected CNS infections, and any patient with sudden reduced level of consciousness. So these are the common 7 C's for brain CT scanning. All right, this help you. I made it to 7 C's so that you can remember quickly. So before we talk about abnormalities or pathologies, it's important for us to understand and be able to recognize normal brain CT. Okay, if you don't know what is normal, you won't be able to identify abnormality. So we're going to go through some of these basic brain structures on CT. We're looking at the skull bones and sutures. We want to look at the gray and white matter, the ventricles and the cisterns, the basal ganglia and the thalamus. And we're going to also look at the midline structures, the vas cerebral and the corpus callosum. The reason this is important is that if you know what is normal, you'll be able to identify what is abnormal. Okay, so the skull bones, we have 5 skull bones, the frontal, in fact 6 as I'm seeing here, frontal, parietal, occipital, ethmoid, sphenoid, and temporal bones. And I'm sure we all know that. All right, all these bones, they ossify separately, but they are gradually become united by sutures. Like the coronal suture, for instance, unites the frontal bones with the parietal bones, while the sagittal structure unites the 2 parietal bones in the midline. The Lamport suture unites the parietal bones with the occipital bone, while the squamosal suture unites the squamosal portion of the temporal bone with the parietal bone. And the metopic sutures, if present, unites the 2 frontal bones, both sides. All right, so this is just what I'm talking about. All right, so you have the frontal bone. This is the metopic suture uniting both of them. The corona uniting the frontal and the parietal, and the sagittal synod, all right, uniting both the parietal, okay? And this is how, sometimes this is important, especially in cases of basal skull fracture, where you're going to look for the mastoid window, you know, especially if you see some bleeding or hemorrhagic changes there. So this is where you look at the window, the bone window from the mastoid window. Okay, so we need to be able to differentiate between the gray and the white matter. You remember the gray matter has the cell bodies, while the white matter has the myelinated sheets, okay? And this gives them their characteristic images on brain CT. The gray matter, you can see from the left image, okay? All right, is usually the outer cortical layer and is slightly hyperdense. Okay, so it's hyperdense, and while the white matter, which is the inner layer, is slightly hypodense. So this is what you see on CT. Okay, this is the gray matter, this is hyperdense, the white matter containing the myelinated sheets, all right, hypodense. This is the image you see on CT. And the cortical ribbon, for instance, and when we're talking about ischemic stroke earlier on, we'll see that during that, there will be what we call the loss of gray-white differentiation, all right? And as we continue, you're beginning to see these structures on the different CT. So we look at the ventricles, all right? And this is an image of the ventricles. We have the lateral ventricles, which are the largest, all right? They are connected to the third ventricle, which is usually in the midline, all right? And through the foramen of Moro, we know that. And the third ventricle, all right, located in the midline, connects to the fourth ventricle through the cerebral aqueduct. The fourth ventricle is located between the cerebellum and the brainstem. Now, this is important. If you look at these structures on your brain CT, you may, because these hyperdense structures, you may think there's an abnormality. This is normal because this is the glomus, or I mean the choroid plexus that produces the CSF, and this is the pineal body. So this is a normal brain CT, all right, despite this hyperdense lesion. So the anterior horn of the lateral ventricles, the posterior horn of the lateral ventricles, and this is important. You need to know the normal, especially when we deal with intraventricular hemorrhage and hydrocephalus. Okay, so the basal ganglia and thalamus, the caudate nucleus is adjacent to the lateral ventricles, while the lentiform nucleus, all right, the putamen and the glomus are closely related, while the thalamus, all right, which is very an important structure in the brain, is adjacent to the third ventricle. All right, these are some of the normal structures you will see. The midline structure, the fast cerebral, all right, is a dura, is a continuation of the dura mater, all right, and it comes, invaginates into the brain structure, dividing the right and the left cerebral hemisphere, while the corpus callosum is a white matter, all right, which connects both hemispheres, the right and the left hemisphere. Sometimes when you have the midline shift, you'll see that the fast cerebral will be shifted away from the area of lesion. And if you have an infarct, it may be shifted towards the area of lesion. So this is why it's important for you to know where the fast cerebral is located, okay? All right, so this is a normal brain CT. Now, in interpreting CT, brain CT scan, there are different ways. People use different ways. You can use the ABCD approach, all right? But I prefer this one because I'm not a neurologist, I'm not a, what's it called, radiologist. I just want to be able to identify some lesions, all right, in my patient. So I like this one. They say blood can be very bad, okay? So blood, you look out for blood, you look at the systems and the ventricular, the systems, you look at the brain parenchyma itself, you look at the ventricles, and you look at the bone, okay? And this is important as we go on in the course of this discussion. So the first thing you want to look for blood. Is there any bleeding? Is there any hemorrhage? Note that acute hemorrhage on CT will appear hyperdense. So you have the bright white on CT. The result is because of the globin molecule or the hemoglobin, all right? And they effectively absorb X-ray beams. Know that as the blood becomes older anyway, especially when we're going to look at acute and chronic hematomas, you'll see that the chronic hematomas become a little hypodense compared to the acute one. The reason is because the globin molecules has broken down and the absorption of X-ray has become a little reduced. But also know that the appearance of blood in the brain CT, all right, changes with time of presentation. Initially, it may be isodense to the brain from 4 days to 2 weeks, depending on the size of the clot, and becomes finally darker, all right, within.
Hey, let's go.
People, let me tell our colleagues, they are disturbing this thing. Okay, let's go on. We can help it. I hope we got what I said about the B, the blood. Any question on that? I think we are fine on that. Let's go. The CAN, the C, systems, all right? You're looking at the CSF, all right? We know the CSF is the shock absorber of the brain, and you want to look at 4 key systems, all right? Examining them for blood, for asymmetry, and effacement, because this will give you an idea into the presence of intracranial hypertension. The circumference encephalic system, you're going to look at CSF ring around the midbrain. All right, it's usually the first to be effaced when we have signs of intracranial hypertension. Look at the suprasellar, the star shape, which is located at this circle of Willis. All right, this is actually where you have your subarachnoid bleed, and that's when you have the starfish appearance of subarachnoid hemorrhage on brain CT. The quadrigeminal system is a W-shaped, all right, is at top of the midbrain, all right, during rostrocaudal herniation, all right. This is the first system that is effaced. The Sylvian system, which is between the temporal and the frontal lobe, is a site of traumatic and sometimes distal mid-cerebral aneurysm and subarachnoid hemorrhage. So you look at them systematically. Then we look at the brain itself. You want to look at the brain itself, and there are so many things you can look at the brain. The symmetry, the gyra, all right, of the gray matter, okay? Is it symmetric on both sides? You want to look at the green-white differentiation, like we mentioned, which is the earliest signs of ischemia, okay? And you want to look at if there's a shift, look at the fast cerebral. Is it at the midline? Look at the ventricles, are they evenly spaced, okay? And then you want to look at the hyper or hypodensity of the lesion. Many of us will look at for hyper and hypodensity, but it's also important for us to look at the symmetry of the brain, look out for green-white differentiation. And by the time you do this regularly, it becomes something you respond to at spinal level. So it's important that we follow that. Then look at the ventricles. All right, is there any dilatation? Okay, we had a case scenario earlier on when we have not communicating or obstructive hydrocephalus, okay? Especially in the temporal horns of the lateral ventricles, okay? Is usually the first to be dilated. Now, but know that you need to take in the whole picture, so to say, to determine whether the ventricles are enlarged due to increased CSF pressure or is enlarged due to effacement or infarction, brain infarction. All right, so taking the whole picture, and that's why it's good to go systematically. Once you rule out any abnormality in the brain parenchyma, there is no infarct, there is no hyperdensity that can shift, that can cause a midline shift. Then you look at the ventricles itself, and if it's enlarged, you may want to know whether they are enlarged uniformly, the lateral third and ventricles, or you have an obstructive where the fourth ventricle appears normal, but there's proximal dilatation of the lateral and the third ventricles. The last one to look at is the bone, which is the highest density. We told you it has about plus 1,000 Hz units, okay? So it appears very wide. Now, know that it may be difficult, tricky to be able to diagnose skull fracture because of the presence of sutures, the 4 or 5 sutures we mentioned. But how do you rule this out? You look for symmetry, all right? If it's a suture line you're seeing, it will be symmetrical on both sides, right and left. But if it's unilateral, most likely there's a skull fracture, which sometimes occurs following traumatic brain injury. And basal skull fracture usually found in in petrous ridge. You want to look for blood in the mastod ear cells, like we showed earlier on. So there are 4 H's in brain CT you want to look out for immediately. You want to look out for hemorrhage, all right? You want to look out for hydrocephalus. You want to look out for herpes encephalitis, where you see hypodensity, all right, in the temporal bone, plus or minus hemorrhage. And you want to look at herniation. Is there any midline shift? Is there any ventricular compression? And don't forget herniation. Sometimes when the neurosurgeon comes, I need to evacuate this hematoma, this patient is going to go on, all right, you will see evidence of herniation, whether onca herniation or any other one. So it's important for you to look at review the CT together. And one of the things I tell my residents, when you engage your surgical colleagues intelligently, you earn their respect. All right, those days where surgeons used to work with nurses and they boss anesthesia around, we've changed that. Like I tell my residents, you may be a neurosurgeon, cardiothoracic surgeon, you chose that. I chose to be an anesthetist intensivist. So I should be on top of my game as you are on top of your game. So when you engage them intelligently, okay, no, but I don't think there's any herniation here. I can't see any midline shift, and the ventricles look good. In fact, I can't see anything. Why are you saying this patient is coning? And look at clinically. So by the time you're able, or you agree, I can see that midline shift. Okay, let's go in. All right. The surgeons respect it because you are engaging them, intellectually. And it's not for the neurosurgeons to come and bamboozle you. Can't you see? No, there's no hyperdensity here. All the structures I'm seeing is eyes dense. The guy will buckle up. Anytime he wants to come and bamboozle you, he will think twice because he knows that you're on top of your game. And that's what I'm trying to do, to make you at par, if not above, any of your non-anesthetic colleagues, okay? All right, so this is just to show you. Now, let's look at the ischemic stroke. All right, let's look at the ischemic stroke. We mentioned in the first, was it the second case scenario or the first one? Okay, so you have a brain CT of a patient, 55-year-old patient, hypertensive, all right, with some neurological deficit, and you order for a brain CT. Now you can see in this area, there's hypodensity here, all right? There's hypodensity. This lesion is darker than the brain, than the gray and the white matter, all right? And you can see that there's loss. You can't usually differentiate between the gray and the white matter, okay? And sometimes you may be able to see a hyperdense lesion in the middle cerebral artery, all right, which shows you a thrombus. That's where that is what leads to the infarct in the first place. So you see this, all right, and you say that, no, this patient is in acute stroke, acute ischemic stroke, and it's important because you need to trombolize this patient, all right, and you want to rule out hemorrhagic stroke before you trombolize. And this brain CT should be obtained within 90 minutes of presenting to the hospital. In fact, that's what they call pain to CT evaluation, and then from CT to needle, all right? So the brain CT will give you a good background to make your decision. So look at hemorrhagic stroke here, all right? Compare with the last one we saw, all right? You can see this hyperdense lesion. This is blood, all right? And it's located in the brain parenchyma, all right? And you can see that there's a midline shift. There's a mass effect. Look at your fast cerebral here that is shifted from the midline, and look at your lateral ventricles being compressed, okay? So there's indeed, all right, a hemorrhage is going on here with some midline shift, okay? And so we're going to differentiate between epidural, subdural, and intraventricular or intracerebral hemorrhage as we go on. But this is just to show you the hyperdense lesion, all right, in the substance of the brain, causing a mass effect with a midline shift in fast cerebral. I hope you can see my arrow, all right, the fast cerebral being shifted away from the midline and the lateral horns of the ventricles being compressed, okay? I hope you can see what I'm showing you. Can you see my arrows?
Yes, we can see, sir.
Okay, great. So let's look at intraventricular hemorrhage. All right, I even still have a patient in ICU with intraventricular hemorrhage as we speak. All right, so you look at the ventricular system and you see hyperdense region, hyperdense lesion here. All right, they appear in one or multiple ventricles depending on the severity and the source. Sometimes you can see both in the lateral ventricles, the middle and the fourth ventricle. All right, so this distorts normal CSF flow. All right, CSF is normally hypodense, and for all you care, this patient may present with features of intracranial hypertension. Okay, so intracerebral, all right, you look at the white lesion within the substance of the brain parenchyma, and sometimes you can see multiple, all right. Later, you know, once the globin molecule, the hemoglobin breaks down, it may become darker, but initially you'll see this white area within the brain parenchyma. So this is intracerebral hemorrhage. Okay, so a patient with traumatic brain injury, there are so many things you can see, all right? There are so many things that come. You can see skull fracture if you look at the bone window, but make sure, remember I told you that you need to look at the symmetry, all right? If it's suture line, it's symmetrical, but if it's on one side, all right, you can see, what's it called, you know, the skull fracture. So traumatic brain injury can present with epidural, all right? You can have the contusion or diffuse zonal injury. You can have subdural, all right? You can have both subarachnoid hemorrhage and interventricular hemorrhage, or you can have just cerebral edema, diffuse cerebral edema, and we're going to be able to appreciate and differentiate each of these pathologies as we go on. Okay, I was wondering. All right. So now, how do you know in terms of intracranial hypertension? The ventricles are compressed. Okay, they are compressed, and the sulcus are effaced. Okay, and you can see herniation syndrome, whether onca, all right, which is more midline, or transthyreal or tonsillar. All right, these are features of intracranial hemorrhage. Our time is going. Okay, so everybody, I've mentioned this before. Now let's look at this lesion. We talked about the biconvex shaped. All right, so this is a brain CT of a patient with epidural or extradural hematoma. Look at it, it's coming from between the skull and the dura, all right? And it has this biconvex shaped, all right? And another thing that differentiated between subdural is because it does not cross the social lines. Don't mind my pronunciation, okay? So this is, if you see this CT image, you should be able to identify that this is an epidural hematoma, okay? So what we're looking at here now is just looking at, this is an acute epidural hematoma, all right, because it's hyperdense, okay? So maybe this is between some few days after the injury. So the light lesion on the right occipital region, all right, is typical and is a surgical emergency. So when your neurosurgeon begins to discuss with you and you see this image, this hematoma needs to be evacuated as soon as possible. All right, so this is another epidural hematoma on this side, epidural hematoma on this side, okay? It's bleeding between the skull bone and the dura mater. So let's look at the subdural hematoma here, all right? So there's a hyperdense lesion beneath the inner tip of the skull, all right? But the inner layer is concave, unlike the convexity of the epidural. So this is concave, and know that it crosses some suture lines, okay? All right, so there's a right midline shift. You can see the fast cerebral here. All right, there's a midline shift and there's a compression of your lateral ventricles. All right, so this is subdural hematoma and it's also a neurosurgical emergency. All right, so this gives you the picture. all right, of a subdural hematoma. Look at the inner layer, all right, is excuse me, is concave, okay, and there's on the fast cerebral is a little shifted from the midline. And look at the ventricles too, are compressed, all right, so there's a mass effect here. Okay, so usually you may, in exam, or you see a patient with acute on chronic, all right, acute on chronic subdura. Look at it now. You can see two types of lesion. This is the isodense brain matter, but look at this apodense region here. This is telling you about chronicity of the subdural hematoma, and this bright lesion here is talking about the hyperdensity, which is the acuteness of the injury. Okay, there's some mass effect, all right, if you look at it, and with the normally placed ventricles being compressed and displaced to this other side, okay. Now, so the other one is when you have an infarct, all right? This could be due to a thrombus in the middle cerebral artery, all right, which is completely dark, okay, loss of brain tissue compared to the normal isodense brain lesion, brain parenchyma here. So this cerebral infarct. And it could also result from hypoxic brain injury, and we've seen quite a number of them like that. Okay, so in terms of infection, okay, you can see this lesion, all right, is ring enhanced, all right, and you can see some perilesion edema, all right. So this ring enhanced lesion that looks encapsulated is pathognomic of brain abscess, okay. And this is important because abscess anyway needs to be drained. So ring enhanced lesion, all right, and it's encapsulated with perilesional edema. All right, if you look at the right one, you see that in the cerebellar space, there is ring enhanced lesion here, and this reflects cerebellar abscess. Okay, tosoplasmosis, especially in immunocompromised patient, you'll see multiple ring enhanced lesions in the brain, and the center of most of these lesions are hypodense, which represent necrotic tissues. Okay, now this was a case of a 24-year-old patient who presented cerebellar symptoms, and a CT scan, a brain CT was obtained, which showed multiple small ring enhanced lesions, multiple, all right? These are multiple, all right? Multiple ring enhanced lesions, all right, in the cerebellum, okay? And there's a mass effect of the adjacent and with the placement of adjacent structures, okay? And a blood test was taken when this was done, and the result came out to be positive for retroviral, all right? So it's common among immunocompromised patients. Cysticercosis, all right? You see the dot sign here. Don't forget that the cysticercosis is a parasitic infection, all right? Unusually common among endemic areas, okay? And these dot signs, multiple dot signs, refer to the what's it called? The scoles, all right? The scoles, all right, of the tapeworm, right? And you can see different, and once you see this, it's pathognomic of cysticercosis, okay? So hydrocephalus, we've talked about that before, okay? And we're going to see, so when you see this, all right, you can see the dilatation of the ventricular system, okay? It's where the lateral ventricles are very, very dilated. Like I told you before, also taking the whole picture, is this hydrocephalus or there's a loss of brain tissue, all right? But you can see that the brains are okay, all right? There's no loss of, there's no infarct, there's no loss of brain tissue. So this is hydrocephalus. And don't forget that these are your choroid plexus and your pineal body. So these are calcified normally in adults, okay? They are not abnormal. The anterior ones lies in the falx, okay? and the two-line ventricles are calcification, the correct process, okay? So in conclusion, brain CT is an essential tool in your critical care, all right? And it provides a rapid assessment of intracranial pathology. So mastering brain CT interpretation enhances your capacity for clinical decision-making in emergencies and ICU setting. Remember that always follow a systematic approach and combine your CT imaging with clinical correlation, and continuous learning is important. So after today, I want you to, every brain CT that comes to under you, whether in anesthesia ICU, make sure you show interest and really practice. They say makes perfect. All right. So these are the references, and we'll stop here today. Okay. Any questions, any contributions we can take? Let me stop the recording now.